Welcome back, future PMHNPs, to Clarity Education Systems and PMHNPtesting.com. I'm Dr. John Rossi, and this is another week, another opportunity to build your confidence, sharpen your critical thinking, and get exam ready. This session is part of our weekly live review for students enrolled in the Clarity Education Systems PMHNP review program. If you're here, it means you're committed to mastering the content and preparing to pass your certification exam with confidence. Tonight, we're tackling high-yield practice questions designed to strengthen your clinical reasoning and test-taking skills. We don't just focus on what's correct. We focus on why it's correct and how to apply it into a real-world psychiatric situation. So, get comfortable, grab your notes, and let's jump into our first clinical case question. So let's start today's session with the neurological assessment case that highlights the importance of cranial nerve examination in psychiatric practice, especially when evaluating for EPS and movement abnormalities. The question reads, a PMHNP is conducting a neurological examination on a patient with suspected EPS and movement abnormalities. The PMHNP instructs the patient to extend both arms and protrude their tongue while observing for involuntary tremors, fasciculations, or asymmetry. Which cranial nerve is being assessed in this examination? Our answer choices are A, the facial nerve, B, the glossopharyngeal, C, the vagus nerve, or D, the hypoglossal nerve. So this is a great example of how neurological findings intersect with psychiatric care. When assessing for EPS or medication-induced movement disorders, cranial nerve testing can provide valuable diagnostic clues. All right, take a moment. Which cranial nerve is being tested here? Okay, if you chose D, the hypoglossal, you're absolutely right. So let's break this down. The hypoglossal nerve is responsible for tongue movement, symmetry, and coordination. So how do we assess for this nerve? Ask the patient to protrude their tongue, observe for fasciculations, tremors, atrophy, or deviation, and then identify asymmetry or any neuromuscular abnormalities. These findings can indicate neurologic disorders, medication side effects, or a brainstem pathology. So EPS and tardive dyskinesia, or TD, with first-generation antipsychotics like haloperidol and some second-generation antipsychotics, they can cause tongue tremors, fasciculations, and dysarthria. Parkinson's disease and neurodegeneration, these abnormalities may be early signs of progressive neurological conditions with the hypoglossal nerve. Then there's stroke and brainstem lesions. So acute tongue deviation can indicate an upper motor neuron lesion, and this is going to affect the corticobulbar tract. So key clinical considerations when assessing for this nerve, we're looking for unilateral tongue deviation, so possible stroke, ALS, or hypoglossal nerve palsy. Fasciculations or atrophy, so this is going to suggest neurodegenerative disease like ALS or muscular dystrophy. Tremors or discoordination, and this can indicate EPS or medication-induced effects. Now let's go over why the other answers choices were not correct. So the hypoglossal controls, like we've talked about, these tongue protrusions, but the facial nerve, the cranial nerve 7, controls facial movement, okay, facial muscles, eye closure, and taste sensation, but not tongue movement. Option B, this is the glossopharyngeal. Now this plays a role in swallowing and also the gag reflex, but it does not control tongue movement. Option C, we have the vagus nerve. So this regulates autonomic functions, vocal cord control, and swallowing, but it does not govern any voluntary tongue movement. So hypoglossal nerve is going to equate to tongue movement and neurological assessment. So this case is perfect for a good reminder of how those neurological assessments intersect the psychiatric care. So this particular nerve, again, is going to control tongue movement. It's assessed by asking the patient to protrude their tongue. We're looking for EPS, tardive dyskinesia, Parkinson's disease. We're looking at cranial nerve testing to help differentiate between psychiatric medication side effects and primary neurologic conditions. All right, great job on this question. Let's continue on to strengthen our diagnostic skills. On to the next case. So let's talk about a crucial concept in geriatric psychiatry: why older adults are more sensitive to medications and at a higher risk for drug toxicity. Understanding age-related pharmacokinetic changes is going to be key to safe prescribing. The question reads, a 78-year-old patient presents for psychiatric evaluation due to increased confusion, dizziness, and worsening depressive symptoms. The patient was recently started on a new antidepressant and an antihypertensive medication. During the assessment, the patient reports feeling more fatigued than usual and has had a recent fall at home. When treating older adults, which of the following best explains why they are more sensitive to drug toxicity? Our answers include A, increased hepatic metabolism leading to faster drug clearance; B, decreased total body fat resulting in lower drug distribution; C, reduced renal and hepatic clearance leading to prolonged drug half-life; or D, increased protein binding of medications leading to reduced free drug levels. Now, older adults often experience significant changes in drug metabolism, especially when it comes to how long drugs stay in their system. So which answer best explains why they are more sensitive to medication side effects and toxicity? All right, if you chose C, reduced renal and hepatic clearance leading to prolonged drug life, you're absolutely correct. So let's take a look. With aging, the body undergoes physiological changes that impact how drugs are metabolized and excreted. So key age-related changes are reduced kidney clearance, reduced renal clearance. This is where drugs are excreted by the kidneys is going to accumulate, leading to increased risk of toxicity. This is things like lithium, digoxin, and NSAIDs. Then we have decreased hepatic metabolism. Phase 1 liver metabolism, CYP450 oxidation, reduction, and hydrolysis declines, slowing the clearance of certain medications like benzodiazepines or SSRIs. Then we have increased fat stores. This is lipophilic drugs like diazepam. They have a prolonged half-life because they get stored in fat tissue. And then we have decreased plasma protein binding, or albumin. So this leads to increased free drug levels for protein-bound medications like warfarin and phenytoin. So why does this matter in psychiatric care? Psychotropic medications, especially benzodiazepines, antidepressants, and antipsychotics, have prolonged effects in older adults. Things like falls, confusion, and delirium are major risks due to increased drug accumulation. So dosing adjustments are critical. We follow the rule: start low and go slow. Clinical implications for safe prescribing in the adult population: we're going to monitor renal function, so things like creatinine clearance, the GFR. Before prescribing, we do this for renally excreted medications to make sure it's good to go. We want to be cautious with anticholinergic drugs, things like TCAs and first-generation antipsychotics, as they will increase fall and cognitive impairment risk. Next, we avoid long-acting benzodiazepines. This is like diazepam, due to this prolonged sedation and fall risk. We choose SSRIs wisely. Paroxetine or Paxil should be avoided due to its strong anticholinergic effects. Now let's go over why the other answer choices are incorrect. First up, we have option A. So this is going to lead to a slower drug clearance, not faster. So that's the reason why that one cannot be correct. This hepatic metabolization decreases with aging, especially in phase 1 metabolism. B, this is your decreased total fat resulting in lower drug distribution. In reality, the total body fat increases with age, which means lipophilic drugs like benzodiazepines, they're going to stay in the system longer, prolonging their effects. Option D, this was your increased protein binding. So the opposite is true in this situation. Albumin levels decrease with age, leading to higher free drug concentrations of protein-bound medications like warfarin, phenytoin, or even VA. So this case is going to remind us that medication safety is critical in older adults due to age-related pharmacokinetic changes. Remember that golden rule: start low and go slow. All right, let's move on to the next question in our clinical cases here. So when a patient presents with new onset depressive symptoms, our job as PMHNPs and providers isn't just to assume it's a primary mood disorder. We have to rule out potential medication side effects first. So many non-psychiatric medications can contribute to mood changes, fatigue, and cognitive impairment, and identifying the culprit can prevent any unnecessary treatment with antidepressants. The question reads, a 52-year-old woman, Sarah, presents for an initial psychiatric intake appointment with complaints of persistent low mood, lack of motivation, and difficulty concentrating over the past 6 months. She reports feeling increasingly fatigued, withdrawn, and uninterested in activities she once enjoyed. Sarah has a history of hypertension and asthma, both of which are currently being managed by her primary care provider. She denies any recent stressors, personal losses, or major life changes. She has never been diagnosed with depression before, and there is no known family history of mood disorders. Given her medical history, which of the following medications is most likely contributing or exacerbating her depressive symptoms? Our answer choices include A. Singulair, B. Hydrochlorothiazide, C. Lisinopril, or D. Albuterol. So this is a classic case of possible medication-induced depression. Whenever a patient develops new psychiatric symptoms, we always have to ask, could their medications be playing a role? So which of these drugs is most likely causing this worsening depressive symptom? All right, if you chose A, you're absolutely right. So Monteclair or Singulair, this is a leukotriene receptor antagonist commonly prescribed for asthma and allergic rhinitis. However, it's been associated with serious neuropsychiatric side effects, and these are going to include depression, anxiety, agitation, and suicidal ideation. In fact, the FDA issued a black box warning for Singulair due to these risks listed. So if a patient presents with new or worsening mood symptoms while taking Singulair, discontinuation should be considered if it's clinically appropriate. All right, so let's review the other answers and why they weren't correct. So B, hydrochlorothiazide, this is a thiazide diuretic used in hypertension. So while it can cause electrolyte imbalances like hyponatremia, that may contribute to some mood changes, it does not strongly associate with depression. Option C, lisinopril. This is an ACE inhibitor used for hypertension, and while some patients report fatigue, it does not have a well-established link to depression. And then option D, albuterol. This is actually a short-acting beta agonist for asthma, and it can cause jitteriness, tachycardia, and anxiety-like symptoms, but it's not known to contribute to depressive disorders. So our key takeaways here, we're always going to consider medication side effects when evaluating new onset psychiatric conditions or symptoms. Singulair is linked to depression, anxiety, and suicidal ideation. We want to watch for this in all clinical practice areas. And then discontinuation of the offending medication can often resolve the symptoms without the need for any type of psychiatric treatment. All right, and so some of the next steps here in treatment with this situation, if Singulair is suspected, so we want to discuss alternative asthma management strategies with the PCP or the pulmonologist. We want to monitor for symptom improvement after stopping that medication. And then if depressive symptoms persist beyond that medication discontinuation, then we consider further psychiatric evaluation. Okay. All right. Great job with this question. Definitely important. Let's move on to the next critical case. So one of the most important skills in psychiatric care is therapeutic communication. How we respond in a way that validates, engages, and guides our patients towards insight and solutions. So in today's case, we're going to explore how to best support a struggling parent while fostering meaningful dialogue and problem solving. The question reads, a 42-year-old single mother presents for individual therapy with the PMHNP, expressing overwhelming frustration regarding her 14-year-old son's repeated behavioral issues. She states, I just don't know what to do anymore. He ran away for the third time last night. I've done everything. I've tried grounding him, taking away his privileges, cut off his allowance, even locked him in his room when he misbehaves. Nothing works. He just keeps pushing me away. What am I supposed to do now? Which of the following is the most therapeutic response for the PMHNP to make in this type of situation? Our first answer selection is A. It sounds like you've tried many strategies, but they don't seem to be working. Let's explore what might be driving his behavior and how we can approach it differently. B. It seems like you're feeling helpless and out of options. Have you considered setting firmer consequences for his behavior? C. Your son's behavior is concerning and it's important to set limits. Have you thought about seeking legal intervention, such as involving the law enforcement or juvenile services? And then option D, running away multiple times may be a sign of an underlying trauma or family conflict. Would you be open to exploring family therapy to address the root of the issue? So the mother is feeling overwhelmed and defeated. She's exhausted every strategy that she knows, and nothing seems to work. So what are we looking for in therapeutic communication, right? We want to validate emotions, acknowledge efforts, and guide towards deeper understanding. So what's the best way to support and empower her? Okay, if you chose A, spot on. It sounds like you've tried many strategies, but you don't seem to be working. Let's explore what might be driving his behavior and how to approach it differently. So in this key answer, this response does the three critical things. First, it validates her frustration when we say it sounds like you've tried many strategies. Next, it recognizes her effort, but they don't seem to be working. Encourages deeper exploration. Let's explore how we might, what might be driving this behavior. So by shifting the focus from punitive discipline to understanding the root cause, we help empower the mother to see her son's behavior as a symptom of an underlying issue rather than just defiance. So why were the other responses incorrect? B, have you considered setting firmer consequences? So this response reinforces an authoritative stance rather than helping the mother understand why her son is running away all the time. The issue isn't just discipline. It's what's driving the behavior. And the option C, have you thought about involving law enforcement? So while safety is always a concern, bringing in legal intervention too early, this may escalate the situation and damage trust between the mother and her son. Building insight first is going to be key in these type of situations. All right, and then option D, would you be open to family therapy? So family therapy, this may be a valuable situation or a valuable intervention later. But right now, his mother needs to feel heard before we introduce any type of solution or intervention. So jumping straight into therapy may feel dismissive of her current distress. All right, so what's next in therapy here? So what should happen next in this type of case? We want to help the mother identify possible stressors like peer conflicts, academic struggles, or trauma. Then we assess communication patterns between the mother and the son. We discuss alternative approaches to discipline and emotional connection, and consider family therapy once the mother feels supported and ready. All right, so this case reminds us that how we respond to parental distress can shape the entire course of therapy. When we validate first, we create space for real change to happen. All right, awesome job. Let's move on to our next question. So when working in community behavioral health, we focus not just on treating mental illness, but on preventing its progression through primary, secondary, and tertiary prevention strategies. So in today's case, it's about recognizing secondary prevention strategies. So let's go ahead and dive in. The question reads, a PMHNP is working in a community behavioral health clinic and is implementing strategies to improve mental health outcomes. The goal is to reduce the impact of mental illness by identifying and treating conditions early. Which of the following represents the best example of a secondary prevention care strategy in community behavioral health? The answers are providing resilience, training, and stress management workshops to individuals at risk for mental illness. That was A. Moving on to B. Screening high school students for early signs of depression and referring at-risk individuals. C. Developing a community-based support program for individuals with schizophrenia to help with that long-term recovery. Or D. Promoting legislative policies that improve access to mental health care and reduce stigma in underserved populations. When we talk about prevention strategy, we have to think about timing. Are we preventing illness before it starts, detecting it early on, or managing a chronic condition? So a quick refresher here on prevention levels. Primary prevention, this is preventing mental illness before it occurs, things like education, resilience, and training. Secondary prevention, this is early detection and intervention, things like screening and early treatment. Tertiary prevention, this is where we manage chronic conditions and prevent relapse through rehabilitation or something like long-term care. So of these choices, which one of these strategies fits the secondary prevention best? All right, clearly here, if you chose B, absolutely right. We're screening for early signs of depression in at-risk individuals. So let's break it down. Secondary prevention is all about catching mental health conditions early and getting individuals into treatment before symptoms become severe. They've got it. We find it. Now we treat it early. Screening for depression in high school students allows for early detection and referral, which helps reduce the severity and impact of untreated mental illnesses. So interviewing early is going to prevent escalation into a more severe depression and reduces long-term disability. This is exactly what secondary prevention is designed to do. So why are the other choices wrong? Option A, providing resilience training and stress management workshops. This is a great example for primary prevention. We're trying to prevent mental illness from developing in the first place, rather than detecting and treating an early stage. Option C, developing a community-based support program for individuals with schizophrenia. So this is tertiary prevention, right? It focuses on long-term management and rehabilitation for those individuals with a chronic mental health condition rather than early detection. All right, so option D, promoting legislative policies to improve access to care and reduce stigma. So while policy change, it does support mental health initiatives, they do not fall under secondary prevention, though, since they don't directly involve early detection and intervention. This is more of a role of the nurse practitioner as opposed to a direct prevention strategy. So let's review it. Just make sure that we have it really stuck in our heads here. Primary prevention. Primary prevents illness before it starts. Secondary, this is early detection and intervention. Secondary screens. And then tertiary prevention, this is going to help manage chronic conditions. So tertiary treats chronic. So why does this matter? Why do we need to know this? You, as the PMHNP, you're going to play a real critical role in screening and early intervention. So early identification of mental illness is going to improve those long-term outcomes. Collaborating with schools, primary care providers, and workplaces, this is just going to increase that access to screening. So how do we apply this in practice? We use evidence-based screening tools like the PHQ-9 for depression, the GAD-7 for anxiety, ACEs for trauma history, and then we implement early intervention programs for at-risk populations. We engage in schools, workplaces, and in primary care settings in mental health awareness and screening. So this case reminds us that screening and early intervention can change the course of a person's mental health journey. By catching symptoms early, we prevent long-term struggles and improve the access to care. That's why secondary prevention matters so much. All right, great job. You definitely see this concept. You will see it on the exam. Make sure you're practicing with all the different levels of prevention. Fantastic work. All right, so let's go ahead and wrap up. This would be the end of our question section in our live session. But it's not the end of our time whenever we're in the live session together. When we have the students online every Wednesday night, the floor is open to them. It's their chance to bring up any questions that they have about the semester and how to navigate coursework, to review programs that they're studying, like the Clarity Education program, and how to make the most of those type of study assets. We look at concepts from the studies. Whatever needs further clarification, we're going to go over it. Practice questions that you've been struggling with and you want to discuss, or really anything that's on your mind as you prepare for the PMHNP certification. So remember, no question is too small or too complex. If you're wondering about it, chances are someone else is too, so we get to ask. So this live Q&A session, it's exclusively available via the PMHNP student portal for currently enrolled students. So be sure to join the discussion if you're a student. If not, join us. Find out more information about how to be a part of Clarity Education Systems. All right, so I want to leave you with a couple words, a couple powerful reminders, if you will, as you continue your journey. First up, from Will Rogers, don't let yesterday take up too much of today. If you had a tough day, tough study day, shake it off. Focus on the progress you make today. Every small step forward counts. When you have a problem, when you have a dream, you've got to grab it and never let it go. This is by Carol Burnett. So your dream of becoming a PMHNP is worth every bit of effort you're putting in. Hold on to it. Keep pushing forward and trust in your ability to succeed. You've got this. I believe in you, and I can't wait to see you in the next session, to see you out in the programs and in our live sessions across the country. Thank you for joining today's session. I'll see you next Wednesday, same time, same place. Until then, keep learning, keep growing, and keep believing in yourself. Bye-bye.